Let's make a start. Hello, everybody online. My name is Alison Schaefer. I work for the WHO in headquarters, and I lead implementation of WHO's Special Initiative for Mental Health. And I'd like to welcome you today to this learning webinar, which has been titled Overcoming Political Challenges to Transforming Mental Health Systems. And I would like to have a special thanks to the Mental Health Innovation Network, who is hosting our webinar today, and a special thanks to a great group of panelists that we have on board. And I'll just ask them all to give you a little wave as I introduce them. We have Sudipto Chatterjee, who is part of our WHO headquarters special initiative team, and Sabrina Hermosilla from Columbia University. We also have Dr. Evans Danzo from the Mental Health Authority in Ghana, and Dr. Kwando Obeng from the Accra Psychiatric Hospital, also from Ghana. And we have Anna Zekaria from the International Alliance of Mental Health Research Funders. And we really hope that this webinar will be able to delve into some of the lessons we've been learning about the special initiative, which continues to be challenged by some of the political aspects that are making it difficult or challenging, I suppose, to institute and constitute change in countries as we work towards improved and transformed mental health systems. So we're going to begin with an introduction from the special initiative, and then we'll go into some specific questions from our panelists over the next hour. I'm not sure if we're going to have time for questions at the end. You are welcome to pose some questions in the chat if you have them. And we also have Giovanni Sala and Ben Adams, who are working on the sidelines in the chat to provide links to some of the articles and references to some of the resources that are being mentioned. And if there are specific special initiative questions, they will be able to answer them for you in the chat. If there are other questions, we might see if we can do some kind of follow-up or summary, which would be posted to the recording of this session. My final comment is that this session is being recorded, and we will have the recording available on both the Mental Health Innovation Network web pages, as well as the Special Initiative for Mental Health web pages. So any other follow-up Q&A can happen through that process. Okay. So without further ado, I would like to invite Sudipto to share his presentation and tell us a little bit about the Special Initiative for Mental Health, and give us an introduction to where we're sitting at now to this point of our webinar and learning series. Thank you, Sudipto.
Thank you, Ali, and hello, everybody. It's a real pleasure to be providing a bit of a backdrop about the Special Initiative for Mental Health and to kick off discussions around that. Next slide, please. So as you would know, the WHO has a long-standing commitment, interest, and focus on the need to expand mental health care, especially in parts of the world where mental health care and services are in a way developing, and where there are huge and very consequential treatment gaps. So the special initiative is a culmination. And in a way, it is a translation and an actualization of these concerns that have been articulated in multiple documents, most recently in the World Mental Health Report, which outlines the huge burden that mental health conditions impose, the great suffering, the human rights issues that are attached to mental health across the world, and the fact that there's an urgent need to provide reliable, quality treatments and services for people living with these conditions across the world. Next slide, please. So the Special Initiative for Mental Health, basically under the stewardship of the Director General, who has a personal interest in making sure that mental health is accorded the kind of importance that is due to it. I mean, the Special Initiative is a big, bold, and ambitious program that has basically the goal that it wants to ensure access for services for mental health, neurological, and substance use conditions to 100 million more people across different parts of the world. And there are two strategic actions that are envisaged, that were envisaged as part of the special initiative to achieve this ambitious goal. The strategic actions were to advance mental health policy, advocacy, and human rights, but then also very importantly to scale up interventions and services across community-based, general health, and specialist settings. Next slide, please. So the special initiative, just to give you a sense of the timeline of this particular initiative, started in 2019, which, unfortunately, very soon coincided with the pandemic, and therefore had a big impact on not just the special initiative, but of course on mental health situation across the world. In 2020, for example, we had some of the assessments, cross-country meetings, and design. One of the key features of the special initiative was that it was very much localized to country requirements, needs, and therefore there was this consultation that happened to kind of determine what were the priorities for each of the participating countries. And in 2021, we had 6 early adopter countries coming on board for the special initiative. And then subsequently, we had Nepal, Ghana, and then Argentina coming on board, making it a total of 9 countries that are currently involved in this special initiative. And across these 9 countries, from 2022 to till date, there has been ongoing progress in terms of responding to the needs and requirements of countries. But basically, the special initiative works with the Ministries of Health very closely, with a range of other partners to try and strengthen systems and make sure that the kind of services that become available are of good quality and provide a range of options for people to access and benefit from them. And then, I mean, as an aside, I think we are planning for the future, and there are plans to have an extension of the special initiative, but I think that may not be too pertinent for the discussions for now. Next slide, please. So the special initiative over these few years has had substantive and significant impact. And as you can see from the figures, it has been able to provide access to services for around 60 million people. In fact, this number is a little higher because we now have very recent data coming in to show that it's gone up a little bit more. So there are 60 million more people who had never had access to mental health services who currently do. And as a consequence of providing these services, we have more than 700,000 people who've accessed the services through the agency of around 35,000 people, healthcare providers who have been trained to provide these services around the MHGAP kind of framework. It's just a good idea to remember that beyond these figures, there are human stories. And it is for many people the first time that they've been able to access services for what is really misunderstood and solitary human afflictions. Next slide, please. And as you can see from some of the figures, the breakdown of these numbers, which follows the general prevalence of these conditions across countries and contexts. Next slide, please. We've also engaged extensively with a range of partners, which is fairly obvious, because that's how we want to spread out services, make it accessible. Next slide, please. And we've had some significant challenges, but also some good learnings. And I won't go into a great deal of detail because that's something that we're going to be discussing. Just to say that one of the most stable predictors of success is the fact that this is a relatively long-term, stable funding, which countries and contexts have appreciated. So I'll stop here and then maybe go back to Ali and ask her to kind of lead the discussion from here on. Thank you.
Thank you, Sudipto. So there is a lot of information about the Special Initiative for Mental Health and what's going on in each of the 9 countries. That's available on the website with the link that's been shared. About 18 months ago, WHO elicited for a midterm review of the Special Initiative, and that was led by Queen Margaret University and Columbia University. And I'm going to pose our first question to Dr. Sabrina, because Dr. Sabrina, your team led the midterm review and recently published an article about some of its earliest achievements, where some of these figures were actually much lower at the time. So progress has been done since that review. And you talked a lot about the factors that have been contributing to those achievements. But under the challenges, you indicated that increasing political prioritisation for funding systems level change remained one of the biggest challenges, and that this was born out of something you termed in your report and publication as ambivalent political commitment and lack of clear funding flows, competing priorities and workforce and insufficient capacity was also challenging. So the question that I've asked you to prepare to respond to is, if you could please summarise for us what this article means by the term ambivalent political commitment and how lack of clear funding flows, perhaps linked to prioritisation for mental health, was observed in this study. Over to you, Sabrina.
Great, thanks, Ali. And if we could do the next slide. Oh, a couple more. I guess there we go. So before I answer the question, sorry, I want to just share 2 figures from both the manuscript that just came out and then from the report from a year or so ago, to highlight what Ali was just mentioning. So in this midterm review, we conducted interviews with over 42 local stakeholders, Ministry of Health officials, WHO staff, and donors across all of the 9 countries at that time. And individuals flagged 153 different challenges across these 42 interviews. And you see here what Ali just mentioned, that top one is ambivalent political commitment. And then the second one is the lack of clear funding flows. If you have the paper memorized, there's actually a ton more. I just highlighted the top few for us to see here. And if you go to the next one, Giovanni. You can see here what we also did in our exploration was try to separate it by type of interviewees. And so here you see the same 5 challenges, but the darker gray at 17% is the group from WHO and regional and donors, whereas the orange is at 13%, and that's from country level interviews. Just highlighting that, yes, this is a key issue, although everybody isn't bringing it up as frequently as we might think. So then for the next one, going back to actually what's your question, where did this ambivalent political commitment come from? I thought sort of the best way to exemplify this for folks would be to just give some quotes and snippets from different folks. Now, for confidentiality, because that sample size might seem large for qualitative folks, but for quantitative folks, we don't want to disclose any country-specific issues. So we're just going to stick to levels of like Ministry of Health or WHO or country-level stakeholders. So this first example, I think, encapsulates it best. And so from a Ministry of Health interview, it was reported that sort of senior Ministry of Health officials, they have other priorities. So at first they agree, they're like, yes, this is what we want to do. But then it gets hard to get time with them. It gets hard to get on their schedules, right? So that's a clear example of this ambivalence, right? It's not against, but clearly if people can't make time for appointments, it's not entirely for. Next one, please. So then, and bear with us, I wanted to pull this all together so you could see how everything contributes. So the next is from a WHO country office interview. And this speaks, especially as somebody who's based in the US right now, and we see all over the world, how important elections are, right? And especially with health systems, we want our health systems to be stable to changes. But this seems to be an issue that is repeating again and again and again. And so we spoke to some folks right before an election, and they said, oh, the elections and the results, they could really change priorities, and that really influences the stability. Next one. Then we spoke to stakeholders, and stakeholders, again, these could be representatives from advocacy groups, from groups with lived experience, and this group really spoke to the local understanding of the Special Initiative of Mental Health. And so this one stakeholder highlighted that the Ministry of Health needs to work to support psychologists and psychiatrists to improve mental health. But other priorities are shifting their focus. It's been alluded to here before that we did this sort of on the tail end of COVID. And so that was often mentioned, but there were other shifting priorities as well. Next one. Then another Ministry of Health interviewee, that Ministry of Health has limited funds, right? And so we need outside, in this case, interpreted as international stakeholders and partners support, outside donor support, outside support. And that also speaks to this, how are we actually getting this stable political commitment? Next one. Then from another stakeholder, political opposition. So sometimes there is actually opposition combined with previous administration's intentions, with current administration support, that these folks are on the ground are kind of in between, right? And they're stuck. And so one group is really supportive, then the other's not. And then sometimes people are not supportive because their predecessors were, right? And the final one from a donor, we wanted to flag that the government says yes, then the work stalls. And this donor indicated it was because from their perspective, it was owing to other priorities. And so then for the last one, Giovanni, how we interpreted these and many other quotes was this sense of ambivalent political commitment. We can think of this ambivalence over time. We can think of it over location, right? Are we talking national, regional, urban, local, right? And also over individuals within the same group and team. So that was sort of our conceptualization, how we got to this ambivalent political commitment. And I appreciate as an academic, that might be too academic-y for folks, but we tried to make it approachable and capture this tension that we saw from the interviews with hopefully some of you on the webinar. Then the second part of this, returning to this lack of clear funding flows, this was the second most common challenge overall. And then when we broke it down, this was actually country level folks indicated this more so than WH regional and donors did. And so in preliminary discussions as we were doing this, we actually thought this would be the number one, but in the end it did not. So some examples about this funding issue and specifically the lack of clarity around it include questions that people asked about, will taxes be used to support these systems? If so, how? Will the WHO continue to support directly or indirectly? Especially when we spoke with the stakeholders, many of them did not know how funding was even, how even this initiative was funded and or how it would be funded in the future. And to clarify, we were not asking this. We asked general questions and this is what they presented to us. Then additionally, one last question people thought about was, will donors continue to support this work? Right. And so this lack of clarity of the flow, as we think about it, we can think about is maybe this lack of clear funding flows is a manifestation, sort of a consequence of the ambivalent political commitment, or is it a cause? And we also need to acknowledge that in these situations, there are tight budgets, right? And so we don't want to be insensitive to the fact that these are really big problems, right? And it's not as if people are saying, oh, we went out and used the money for something inconsequential. These are really hard challenges to balance. So at the end, what we're really left with is this lack of clarity
1 minute.
of funding. Yeah. Is it a symptom of the political ambivalence or is it a cause? And maybe it's both. But that's where I'll end here. And if we have time, I'll take questions. Thanks.
Sabrina, that is super clear and thank you so much for sharing that. So I think some people think that the lack of funding is because governments don't want to fund, but it is actually a challenge for governments because of all these shifting priorities, and the two are inherently linked. You know, if the political commitment is there, then maybe the funding flows could be found, but then maybe they don't have the ability to change the funding flows. So I imagine that probably looks quite different in different countries. Yeah. And just to give you a bit of a response, when the achievements were actually also documented, and these are documented in the article, one of the ways that we can foresee that has been an achievement of the special initiative to help overcome some of these political challenges, it's been that we've had consistent staff in country offices that have been able to be that foundation for changing parties, political change and actions that have happened in the country. And so one of the ways to overcome some of this political or ambivalent political commitment has been to have strong champions in the country that are still working towards the long-term vision so that they can bring new actors in government on board to continue the vision being seen forward. So I think that's, that is documented in the article.
Yeah.
And I think that's an important factor that could help overcome some of this ambivalence and some of these political challenges. Thank you so much, Sabrina. Our next two speakers are directly from Ghana. And one of the reasons we selected Ghana for this learning webinar is because Ghana has recently made some really strong inroads in making some substantial political changes. And in two ways that's happened over the last few years. One of them has been the decriminalisation of suicide, and another one has been the inclusion of mental health conditions under the National Health Insurance Scheme of Ghana. So my next question is to our panelist, Dr. Evans, and to say that as part of the special initiative in Ghana and with the Mental Health Authority, there was collaboration for these mental health conditions to be included in the National Health Insurance. And this will ultimately mean that in Ghana, hundreds of thousands, tens of thousands, we're not sure of the numbers yet, but many more will have access to government-funded mental health services. And this is an enormous achievement for Ghana. So the question we're posing to you is, if you can tell us, firstly, what was the role of Ghana's Mental Health Authority towards the inclusion of mental health in the National Health Insurance Program? Secondly, what was one of your greatest challenges throughout that process? And thirdly, how you overcame that challenge. Over to you, Dr. Evans.
Right, thank you very much. This really follows up with the previous presentations. And primarily in Ghana, Mental Health Authority has played a central role in advocating for the inclusion of mental health into the National Health Service, National Insurance Service, primarily because that is the main role that Mental Health Authority is supposed to play. And basically, there are four key actions that Mental Health Authority played in order for us to be able to achieve that. So first of all is the policy dialogue leadership. The Mental Health Authority actually spearheaded formal correspondences and then meetings with the National Health Insurance representative, which enabled us to make a compelling case for the policy inclusion. Then the second, with the support also from the WHO, we're able to facilitate the collection and the presentation of comprehensive data throughout the system for the actuarial studies and analysis, and that also informed decision-making by the NHIS. Then again, the Mental Health Authority also coordinated efforts for advocacy in that bringing together civil society and development partners and then government officials, including the academia, for us to actually make or create a unified advocacy strategy, which actually helped in pushing up for that. Then the fourth one that Mental Health Authority was engaged is to organize some stakeholder engagement sections, and particularly with support from the Ghana Somobi Jumedie to build awareness and the Ghana support for this initiative. Next slide, please. Yeah, to look at the question of the challenge, one of the greatest challenges was actually the financial and operational concerns that the NHI stakeholders had. There was resistance rooted in the perception that including the mental the mental health conditions into the health system was going to affect the sustainability and then operational capacity. We believe that this skepticism was amplified probably also with a lack of understanding of the long-term benefits that the mental health inclusion would have if it was included in the NHIA. Next slide. Now, how did we manage to overcome this challenge? First of all, the MHA provided data for the actuarial studies demonstrating feasibility and the long-term cost effectiveness, including a mental health service in the NHIS package. And then also by bringing the 4 conditions, that is the schizophrenia, bipolar disorder, anxiety disorders, and then depression as a case to start with. Then strategically, we also build relationship with the key stakeholders, including the NHI leadership and the actuarial team, who actually played an influential role in this. And then we were clearly able to communicate the situational realities effectively and then emphasize on the societal and economic benefits. We also leverage on the goodwill and the partnership that MHA had with credible partners, the WHO, the FCDO, and the civil society organizations who actually help extensively in advocacy efforts and then persuasive directions for us all to have the collective arguments for the NHIA to actually accept these conditions into its inclusion. So let me quickly also generally say that this multifaceted approach that was engaged by MHA not only addressed the concerns, but also created a foundation for a long-term collaboration in advocating for the policy to include the mental health conditions in the NHI. Thank you. I think this is what the Mental Health Authority actually went through to get this included in the NHI. Thank you very much.
Dr. Evans, thank you so much for your contribution. You've taken 5 minutes to explain something that has taken you, can I ask how many years did this take?
Yeah, it has taken close to about 5 years.
Yeah.
For us to, yeah.
Yeah. Congratulations to Ghana, to your mental health authority, and to all of your partners. And I know there's a lot of NGOs on the call, and perhaps CBOs and service user associations. And for me, one of the key messages that I'm hearing from you is the importance of, the words you used were policy, dialogue, and data, and I think they're important, but the key words for me were coordination, the goodwill, and multi-stakeholders and partnerships. And I think for us to really work towards that political change, that coordination of all the partners in the country need to be coming with a common key message and a common goal towards a political change. And I think you've really shown how that's happened. But also, I just want to acknowledge this didn't just happen overnight. This took a long time and a lot of coordination from people who are sustained within the country over a period of time and a period of years. This is a huge achievement for Ghana, and congratulations on that. Our next speaker, Dr. Kwando Obeng, is from the Accra Psychiatric Hospital. And another huge achievement for Ghana was about 18 months ago when Ghana finally decided to update a very dated mental health law, which was criminalizing attempted or suicide attempts. And it was in June 2023 that Ghana actually made history by updating that. And suicide has now been officially decriminalized in Ghana. So, Dr. Kwando, thank you for joining us. And the question we've posed to you is, can you tell us about what it took for this age-old law to actually be overturned? And how did Ghana's mental health community, including professionals, service users, amongst others, actually get political traction to elicit this change? Over to you.
Yeah, thanks for having me. It's very similar to what Dr. Danso was talking about. Everybody got on board to make this happen. There's no single group that was not involved. And this has been going on for over 10 years. So, I mean, it started with a lot of lobbying, a lot of media engagement, bringing up the topic, getting the public to try and understand where we were coming from. So this is Mental Health Authority, this is the various professional organizations, the Psychiatric Association, the psychologists, service user organizations, civil service organizations, NGOs, just kept on hammering the message again and again and again. Eventually, when we started getting some traction, we even deviated. The Mental Health Authority chose to deviate from the topic for the mental health day for a particular year from the WHO topic, because we had some traction on suicide. So we thought we should just make it about suicide that year. So it was a very concerted effort to keep it in the public discussion. Fortunately, at some point in time, the media partners got engaged as well, started reporting more actively, unprompted, on attempted suicides, going into the stories of individuals who had completed or not completed their suicides. And we had a couple of high-profile cases, but particularly involving university students, some medical students, which sort of kept the narrative going. And every time there was one of these opportunities, like I'm saying, everybody jumped in from whatever angle they were coming from to make sure that we were getting heard on the problems that this law is posing to us in terms of treatment, in terms of getting accurate data, in terms of people hiding from the medical services that they needed. And then we also had a lot of work done from academia. We had a lot of researchers who had dedicated themselves to studying suicide patterns in Ghana and publishing, and always disseminating this information, which also helped to fuel the discussions that were being had in Ghana about the issue of suicide in Ghana. The Department of Psychology at University of Ghana did a lot of work on this. The current MHA chief executive did this as a topic for her fellowship. So there was a lot of academic interest in this topic as well at the time, building up. This eventually led to a coalition of, again, NGOs, CSOs, government partners coming together. Somebody had a link with the Chief Justice at the time and managed to convince her to allow us to do some engagement with the judiciary. So we went around all of the 10 regions of Ghana at the time, educating judges about the medical aspects of suicide and the challenges that we're having medically with the law being, criminalizing suicide. So this was done. And a nice touch for this program, which I would recommend for anybody who wants to do something similar, is that we added a component on stress management for them. So it was like a stress management workshop where we happened to educate them about suicide and the challenges we're having with the law. So the judges loved the stress component, and we hope they picked up something from the suicide bits. And then we got to the nuts and bolts, trying to get to engagement with the parliamentarians going. So again, everybody got on board. I keep on repeating it, but it was everybody's. Yeah. No, you can't single out anybody. And what was interesting is that initially, you had an understanding from the parliamentarians that reflected the understanding of the people. So there was a poor understanding of the biology behind it, the psychology behind it. And there was a genuine belief that the criminalization of suicide was serving as an effective deterrent against, suicide. So this took a lot of educating to let them know that where the person's mental state is at the time that they're continuing taking their life, a law is not really a big factor in their decision making. So eventually the parliamentarians got on board. They understood exactly what we're talking about. And then we found out what our real problem was. The parliamentarians were concerned about their electorate. they didn't want to be seen as the pro-suicide candidate. So they understood that we're saying they should be pro-decriminalization of suicide and not pro-suicide. But they threw the challenge back to us to go back and educate their constituents to know the difference between pro-decriminalizing suicide and pro-suicide. And once their constituents were on the same page as them, they assured us they wouldn't have any problem decriminalizing the act in Ghana. So again, the job went back to us, and again, the same coalition, WHO, CSOs, NGOs, everybody got on the ground, one-on-one meetings, so on and so forth, media engagements. And eventually, when the parliamentarians were comfortable with what we're doing and what we're saying, they decriminalized the act. We also benefited from a relatively stable parliament during this period. So the same people came back, the influential people came back, so we were able to make some progress. So the key takeaway is that no single entity can take responsibility for it. It was a team effort from beginning to finish. And it was important to fully engage with stakeholders and understand what their concerns were. Because when the parliamentarians told us about them being concerned about our constituents, nobody was expecting that. It's new information that we had to work around. So actually engaging with people, not assuming you know where they're coming from, was a very important thing for us. And also simplifying the message. We medicalize suicides intentionally because it's the simplest message that could go down easily and was easy to sell. It's more nuanced than that, but a simple message always goes further than a complicated one. Thank you.
I'm finding these stories from Ghana so inspiring because it tells us that change is possible and political commitment and political change is possible. I'm just hearing more and more this message of coordination, consultation, key messages, simple messages. I'm also hearing the time that it takes, 5 to 10, 5 years for insurance, 10 years for decriminalizing suicide. And it's interesting because Dr. Danso mentioned data, and you, Dr. Kwando, have mentioned academia all played an important role. And that's a really nice segue to our final panelist today, which is Dr. Anna. Dr. Anna is from the International Alliance of Mental Health Research Funders, which has an even more complicated acronyms. But Anna, you recently organised a symposium, in fact, that was held last week, which was about the contribution of a systems approach to bridging the mental health research implementation gap, including issues around governance and leadership. So the question that we've posed to you is, could you tell us a few of the insights and conclusions from your symposium that might help some of our listeners today think about overcoming some of the political changes they're facing in their countries to transform mental health systems and services? Thank you, Anna.
Thank you. And thank you so much for inviting me to speak about the lessons from this systems symposium. And I think the organisers are going to share a link in the chat to the full recording as well. So hopefully people can listen to that. So IMHRF, which is how we get around the acronym, exists to bring funders together to address pressing and cross-cutting challenges in mental health research. And one of those challenges is this persistent research implementation gap. So this session was the first in a series inspired by the Lancet Psychiatry Commission on transforming mental health research implementation. We started with the big picture, considering what we mean by systems thinking, and then looking at different aspects of systems strengthening. And one thing that really came through loud and clear is that the political sphere is part of the mental health research and implementation system. But when this social context is kept separate, real world needs aren't integrated in the way they need to be from the beginning. So next slide, please. So I think what came through was finding ways to bridge that disconnection emerged as the big challenge. And we talked about how the solution starts with how we conceptualize the system. So Professor Jeffrey Braithwaite impressed upon us that complexity is the real state of affairs, even though it's much easier, obviously, to try and think of these things in linear terms. But actually, that linear thinking is the root of where we fall down. So if we embrace complexity, we start thinking differently about the questions we ask through research, and then how we go about research and implementation. So If first we confine systems thinking to the health system, we might think about that in terms of meaningful engagement with end users, in terms of the research questions that are asked in the first place and how that research is done. But as we've been discussing today, the health system doesn't represent the limit of the mental health system, both in terms of the social drivers of poor mental health and the solutions that can support good mental health. So what came across in the session was that we exclude decision makers in other parts of the mental health system from our research and implementation at our peril. We really need to understand who they are and the problems they're trying to solve, which I think we've heard from the other speakers today. And we know that they're likely to be wider than mental health. And they're going to be working under lots of different constraints. So we have to be approaching them kind of mindful of all of that context that they're dealing with. So I think another message along those tracks was that top-down solutions, so those that are developed without this recognition of the complexity of the system, they've got less chance of being a good fit. So when we develop solutions with a complexity lens, that means our eyes are wide open to the reality of that context. And there's no one size fits all. That context will differ by the setting. And I think it's what we were talking about is when you start thinking like this, it's easier to start to name those individuals, those groups, those parts of the system that really need to be engaged and bring them into the room. So next slide, please. But what we also heard that working with the complexity lens, it requires structures and ways of working to harness those benefits. And one of the models that we talked about in detail was the learning health system. And that's systems that amplify the voices of those experiencing care through knowledge, data, and practice loops, with the aim of making that care relevant and meaningful. And on the governance front, doing this well means it means we have to invest in a learning community at the heart of that system's governance. And that means engaging all the partners that have got a stake in the change. So I think there are a few ways to work with that model in the context of today's session. And first, it's how a learning health system can itself help address political challenges. So what are the kinds of evidence that this sort of system can generate? And how might that be used for advocacy, for impact, for learning? And I think including culture in this model helps us think about the impact of cultural norms and beliefs around mental health. And we've heard how important it is to surface some of those beliefs. And I think something around the political imperative to tackle stigma as part of unlocking health system and engaging with the health system in the first place is really important. And then I think that finally the principles itself of the model might help us conceptualize a learning mental health system that's wider than health, one that explicitly includes those cross-government priorities, connectivity across schools, work, community, criminal justice systems. And on that last point, we heard from Rosemary Gathara about how Basic Needs, Basic Rights Kenya starts at the community level and then works with a range of government departments to understand how solutions fit with local resources. And what she told us is to do that work, to strengthen her work, she needs data on the social return on investment and ideally also the economic return on investment. Next slide, please. And I think understanding what matters to people, and that's, we've heard that time and time again today, including policymakers and politicians, is about taking the time to understand people's needs and to co-create solutions and evaluation together. And this is a long-term endeavour. We've heard it doesn't happen overnight. And that can be a challenge when you've got the relatively sort of shorter political cycles that, we're working within. So we talked about how other parts of the mental health system can build resilience through investment in those relationships and networks. So, for example, Dr. Bibi Oladeji talked to us about the need to generate political will and doing that by investing in the leaders who are going to engage in that sort of form of evidence-based advocacy. And we've heard about long-term funding. So funding mechanisms and other funding mechanisms can support a long-term approach as well. We heard from Being about how the initiative works to support youth mental health innovations in specific local contexts. They create research networks and enabling environments for scaling by bringing in all those actors from the beginning. So I think that systems resilience and building that systems resilience by actively shaping research and implementation to suit the local needs and context from the start means that by definition, those political considerations and challenges are weaved in. And that means the system's more likely to be able to anticipate and then withstand changes in sort of the political weather. Next slide, please. So I think the message about systems thinking helping unlock transformation for mental health, at the heart, it means embracing complexity. But I took heart actually that really it means that this is about people, and it's about grounding the work, the multidimensional reality of what we're trying to do, and embracing the fact that people have got competing, sometimes kind of different priorities, but really taking the time to understand them. And that takes resource and it takes time. But there are practical things that can support it. And I think that is prioritizing those bottom-up innovations and perspectives. Thinking about what different stakeholders need to evaluate success. They're often looking for different things in different domains, and really understanding that means we can be measuring things at the right time for the right purposes. And I think the other thing that really came across strongly was the need to embed a learning culture and invest in those networks. So thanks for listening. I hope that was a helpful summary and that you enjoy listening to the recording in full when you have a moment.
Thank you so much, Anna. I actually think we're hearing some common themes coming through all of our speakers, and I want to say, as lead for implementing the special initiative, I am a huge advocate of saying complexity is our reality. Every country has a common theme in the special initiative and common themes, but each functions in their own way, and each functions in a different way. And things are never always the same, as we heard from Sabrina at the beginning. You know, priorities shift and change over time. But then I think having some of that learning culture that you've spoken about, Anna, having some of those consistent coordinated partnerships and advocacy programs together that we've heard from Ghana, I think all of those things are ways that we can try and go with the flow of complexity. You know, I think if everyone is complex and they're not coordinated together, then how are we ever going to address the complexity if we're adding to the complexity? So perhaps, you know, the coordination message and the timing message is all critical, because that's what could potentially help alleviate some of that complexity environment or complexity context, and then also help us actually institute some learnings along the way and build that learning culture. I do think the learning culture might take even more time. Like, I think that's something that is perhaps a little newer to some of our countries, but I think it's something that has the potential to grow in the coming decades, and might be you know, our next generation of global mental health too going forwards. It's really hard for me to see how you're all responding to our speakers, because I don't actually get to see all of you. But I just want to say, at the bottom of your screen, there is a Q&A box, and I encourage in particular our Ghanaian colleagues and speakers to look at that, because there's some really encouraging comments in there about what's been going on in Ghana, and some thanks for the presentations. There has been a question around blood results around mental health and scans. I don't kind of want to go into that, because I want to stick with our political challenges and achievements that we're talking about today. But there are a couple of questions one question that I'd like to throw to Dr. Kawando is whether there was any narrative of changing faith leaders' thinking or approach towards decriminalizing suicide in Ghana.
Yeah, that was a significant component as well. I forgot. There's so many invested groups when it comes to the topic of suicide. So yes, there was a lot of work done with the various religions. It's mostly Christianity and Islam here.
Yeah.
You know, yeah. So there was a lot of engagement with the religious leaders as well, so that they didn't oppose us when it got to Parliament, because that would have been problematic.
Yeah, I think that's a really critical point, and it's why I've highlighted this question, because I think our faith leaders play a huge role around stigma and discrimination and the potential to alleviate that. I think we have a huge opportunity across our faith communities to be addressing some of that stigma and discrimination. But the decriminalisation of suicide is tricky because suicide is viewed in particular ways by certain religious communities. So I think there's some important messages there. And you know, I really liked what you said, Dr. Kwando, and also what Anna just said is we can't always anticipate we know the answers. You know, I like this notion that in these complex environments, we need to actually go in with some openness and some readiness to hear something that we weren't quite expecting. And I think each context in the religious communities might be a little bit different. And there may be some approaches that we could use that we haven't even thought of yet. So the co-creation is really important too. I think our service users have a lot to contribute as well. I think, you know, they're going to be key to some of this messaging and some of this advocacy, but I would encourage our service users to do that in coordination as well. Because everyone needs to be, we say in old terms, everyone needs to be singing from the same hymn sheet. That's what they used to say. Okay. I'd like to kind of leave it there on the Q&A for the moment. I know we haven't had a lot of chance to go into all of that, but I just want to provide our guest speakers, Dr. Sabrina, Dr. Danzo, Dr. Kwando, and Dr. Anna. I've asked them all if they could give us a 1-minute summary from what they've been hearing today. And something that you might post online, such as the old Twitter or the current X, something just really short and brief, and tell us if you've got one lasting message for us. So Dr. Sabrina, you first.
Sure, thanks. Oh, my camera's not coming on. Apologies. I changed as I was listening because I want to say that complexity is key, and the complexity is our reality. And that is what can stabilize and support against instability. It ended up not so eloquent. Thank you.
Okay. Thank you, Sabrina. Dr. Evans.
Yeah, hi. Good, great. What I would say is anything that we purpose to do, we have to engage it with a conscious commitment and then get the right skill to approach it. And then we are able to do it. That is a typical example of what Ghana is demonstrating now.
Great. Thank you, Dr. Danzo. Dr. Kwando.
Sorry. It's extremely important to keep your message simple so you can collaborate with as many people as possible. So it's sort of contrary to what she was saying. In your complexity, you require simplicity.
Okay. Thank you. And Dr. Anna.
Thanks. Yeah, I think building relationships to understand each other, and including surfacing these assumptions and beliefs that maybe we wouldn't have been aware of going in, and then identifying, what evidence is needed to support a case for change or to develop a case for change. How do we build that case together?
So in some of my notes, I'm saying in the simplest terms, with simple messaging, it's going to be important to commit to coordination, to co-creation for change, to collaboration, and to relationships to move forward and overcome political ambivalence and political challenges to mental health transformed mental health systems. That was a lot harder to do live than I had anticipated. So I might make a recording of that, and we might summarize that in those final statements when we put online the recording for this message, for this webinar. So this webinar will be put online on the Mental Health Innovation Network webpage, WHO's Special Initiative for Mental Health webpage. And this webinar today has been part of a commitment we've made in the Special Initiative to do at least 2 learning webinars per year, so that we are sharing some of our experiences and some of our learnings as we go along the way across multiple countries. And I'm really excited to say, if we can have the next slide, please, please, Giovanni. I'm really excited to say that in towards the end of February, maybe early March, we haven't quite set a date yet, but the Honourable Julia Gillard, who was Australia's first female Prime Minister from 2010 to 2013, has agreed to speak for the Special Initiative for Mental Health in Q1 2025. And we're going to start talking to her a little bit about how we can get mental health more on the political agenda. And the reason that we've selected Ms. Gillard as a representative and a deep dive guest expert in this area is because she was enormously successful in introducing a national disability insurance scheme in Australia for the first time. She has been a chairperson for Australia's Beyond Blue Depression Initiative, and she's currently the chair of the Wellcome Trust. So she understands a lot about the research. She understands a lot about the needs for mental health and psychosocial disabilities, but at the same time, she has that real political experience as a former Prime Minister that might actually provide us even more details and expound on some of the technical elements that we've been talking about today. So please watch that space. I'm really excited to be interviewing excuse me, to be interviewing Ms. Gillard in the new year. She's not only been all of those things, but she's also been one of my heroes as a woman in leadership. So I encourage you all to watch this space and join us in the new year for our next webinar, which will feature the Honourable Julia Gillard. So we are at the top of the hour now. Thank you everybody for attending. We at one point had well over 100 people attending today. I want to say a huge thank you to our speakers. We've got hearts and emojis going all over the screen. And we look forward to hearing from you and joining you in a future learning webinar for WHO's Special Initiative for Mental Health.